Hello, good evening from me as well. I know it's late and everybody's tired, so I will try to be quick. In the next few minutes, I will present you a case, TAVI case with valve-in-valve with MYVAL valve. These are my potential conflict of interest. Our patient is a 88 years old male with multiple hospitalization during the past months with pulmonary edema, fatigue, and dyspnea that has been worsening for the last 6 months, and his current NICA status is almost 4. From the rest medical history, he has diabetes, he has hypertension, he has coronary artery disease with a recent PCI in the midsection of LAD, and has a surgical aortic valve replacement with a mitral flow 23 millimeters, 2015, and has a chronic kidney disease with a calculated GFR of 43 ml per minute. From the echo findings, we have a preserved ejection fraction with 50 to 55%, a stenotic aortic valve with max velocity 3.2 meters per second, and then calculated AVA 1.1 square centimeters, and severe regurgitation with pressure heart time approximately 200 milliseconds, but with intraprosthetic regurgitation mostly, and with a little PVL. Also had a mild to moderate mitral regurgitation. His ECG is in sinus rhythm with left bundle branch block, and his calculated Euroscore is quite high. It's 11.23% for fatal surgical risk. From the measurements we got from the CT, we can recognize that there is a quite low height of the left main. It's 5.1 millimeters. And the dimensions that we measured from the annulus, the mean diameter was 19.6, and the average dimensions was 21.6. But we know by default that when we have a mitral flow 23 millimeters, the true internal diameter is 19. The rest measurements from the CT was okay. We have a right coronary artery height at 14.2. We have a satisfactory dimension of left ventricle. Our ankles were good from the aorta. And the working projection will be the implanter's view, which is an LAO 18 and a cranial 6. The peripheral arteries were okay. The dimensions were wide. We have multiple calcification in the aorta and low bifurcation in the femoral arteries, and the calcification over there hopefully is placed mostly on the posterior wall of the artery, so there won't be a problem for us to cannulate there. From the echo, from the TOE, you see both long axis and short axis. You see the stenotic surgical valve. You see the regurgitation at the color Doppler. The same findings from different ankles. You see the severe regurgitation, and also in the images from the 3D TOE and the color Doppler images. So we have to decide to be the patient under light sedation and local anesthesia. Our main access site will be right femoral artery, so we perform the TAVI from there, and the left femoral artery, so we can cannulate the left main. From the TAVI, from the valve selector app, we see we have multiple choices, but we choose a balloon expandable valve, so we can have the smaller frame like here, and we have MYVAL 23 millimeters. And of course, we choose to protect the left main. Getting started, this is our initial aortogram in implanter's view, which is LAO 18 and cranial 6. And we quickly cannulate the left main with a guiding catheter of Judkins left 4. And we place a wire in the left circumflex artery. Then we place a stent ready for use in the left main. It's a Synergy 422 millimeters in the left main, and we smoothly advance our valve in the position that we want to deploy it. You will notice that we have only two axes arterial, because in this particular case, We have the guiding for the orientation for the implantation view from the ring of the surgical valve. Unfortunately, I don't have the video that we deploy the valve. But after the valve deployment, our first concern was to check the left main patency. So we took a selective projection through the guiding catheter, and we were satisfied with the result. There was no obstruction of the left main. And so because we have the two arterial accesses, we proceed with withdrawing the stent and the guiding catheter there and advancing a pigtail to have an aortogram. At this point, our patient starts to deteriorating. He's becoming symptomatic, he's increasing chest discomfort, he starts moving, he starts complaining about chest pain. We have a mild fall of blood pressure, but the ECG is stable. There are not any pathological changes, but the first thing we think at that moment was the left main. So we got back at the last taken projections, and we really checked very closely. And we see that, you see over there, there is a white shadow that is touching the stent. It's the prosthetic leaflet which is touching the stent. And when we checked also the projection without the guiding catheter, you see that the leaflet of the surgical valve is really higher after the removal of the stent. You can see the difference between those two images. So there was nothing left to do. We quickly re-advanced the guiding catheter, and we placed the guide wire through the left main, and there was a semi-compliant balloon 3.520 to predilate the left main. Here we discussed about using a guide catheter extension, but because the frame of the valve was lower than the left main, we thought that we can manipulate all from there without using the guide catheter extension. After that dilatation, the patient was getting more stable. The blood pressure would start getting a little bit higher, and it would start feeling a little bit better. So we repositioned the stent at the left main. We checked in an orthogonal projection in an apicodal the position of the stent, so that we can protrude satisfactorily in the ascending aorta and covering the left main. And we deploy the stent. It's a Synergy 422 millimeter stent. And we immediately check the result, which is, I think, acceptable. We did a flaring post-dilatation in the proximal edge of the stent with a stent balloon, and after post-dilatation, I think that the result is even better. We checked, of course, the result in the apicodal projection, which we should have taken from the beginning, but we felt confident about the first result. And we see in a closer look that the stent is protruding satisfactorily in the ascending aorta, but in the middle section of the stent, it's a bit underexpanded. So we choose to post-dilatate. You see over there. We choose to post-dilatate with a non-compliant balloon, 4.512 quantum balloon, and this is our final result. You see the regurgitation, that it's the PVL regurgitation, because hemodynamically measured, there were no intravalvular regurgitation, so we were happy with this result, and we also with the depth of the valve, which you see it's a bit deep implantation, but we did that intentionally, so we didn't compromise with left main ostia. After 4 days and a permanent pacemaker for an asystole episode the 4th day, 2 sessions of dialysis, the patient was discharged stable at good general condition without signs and symptoms of ischemia, dyspnea-free, and his current NIHA status was 1 to 2. We have a mild regurgitation, which is mostly PVL, and a mild stenosis with a mean gradient hemodynamically measured at 11 millimeters of mercury, which was acceptable at the time. The take-home messages, the advantages and disadvantages of a patient under local anesthesia and sedation. If our patient was under general anesthesia, he wouldn't be able to tell us that he was feeling discomfort. We wouldn't be able to say that something was wrong because the ECG was stable. Because a mild fall of blood pressure in a TAVI procedure, it maybe will pass unnoticed. So it was an advantage that we have him with light sedation. We should always check the result at least at 2 vertical projections. If we have done that from the beginning and it wasn't, and we weren't so confident about the good result, maybe we have avoided all the rest of the procedure. And finally, follow the initial strategy, which is prior discussed and well organized. We have from the beginning choose to protect the left main, and this is what we should have done. Because if we have done the chimney procedure, we wouldn't have to hurry up so much the rest of the procedure. Thank you very much.
Okay. Congratulations. Antonis, we did the case together, and I'm not very proud of this case, but we should always report our faults. So I think the good thing was that it was a MYVAL valve, so it was very easy recannulating the left main. Are there any questions? Dr. Tsalamandris, what is your opinion?
Yes, hello everybody.
Any suggestions from the audience?
Hello everybody. A very nice case, very interesting case, and a very difficult case. I think that after finishing the deployment of the valve, having the fall of the pressure and the feeling not well of the patient, it was a little bit scary because I know these things. I have been many years ago in this situation. You have done everything well. The result is very nice, and as Dr. Kouparanis said before, we always have to check 2 or 3 times, especially in 90 degrees view, to see the result, so that we can be sure that everything is okay. Very interesting, a very difficult case. Congratulations.
Thank you very much.
Any other comments from the moderators? Actually,
after
yes, Grigoris, yes.
After the position of the valve, what was the first diastolic pressure you took? Because you know there was a severe, as you said, severe PVL. And
the PVL we all know mild. The most regurgitant volume was from the intravalvular, from the surgical valve.
But initially, I have to congratulate you, Adonis, for the case, both Adonis. But the question is, we all know that during diastolic phase, we have the flow to the coronary arteries. And of course, you have to remember that if we have low diastolic pressure, and of course, it has connection with the leak we had. This could be a very severe reason for the symptoms of the patient. That is the question. That's why I said it's very easy to recognize this issue if you see a very low diastolic pressure.
Anyway, I think we have. In this case, actually, we hoped we will have Dr. Kilic as a proctor because we did 2 very difficult cases with him, but he couldn't able to get on the plane. So, any suggestions?
Antonis, you should proud of this case because this case was very hard case because of the property of the mitral flow. As you know, the leaflets are mounted external side of the mitral flow. In all studies, also which was published in Eurointervention with self-expandable valves, always chimney technique were used to prevent the risk of development of coronary obstruction. In this case, selection of this valve also good selection compared to the other balloon expandable technologies, because you were lucky because of the selection of this valve also, because the upper side holes of MYVAL is larger than the other comparable balloon expandable valves, 6 millimeter circumferential diameter. So these also protect during the case. But my approach will be same, but I don't, I will put the stent as quickly as after the implantation, because you can see that the external amount of the leaflet is seen in different projections. So it is better to learn everything step by step in every case. We are still learning property of new valves, also old valves. But the most important thing is to investigate the surgical valve before the procedure, and you did it. I know, because you several times look at the CT, and we also discussed. So congratulations about this case.
So by knowing that the height of the coronary was just 5 millimeters, you would have stented the case anyway, whatever was the angiographic result after the valve implantation.
Because late sinus sequestration can occur, or if you put, for example, a self-expandable prosthesis. If this was, for example, self-expandable, it was immediately blocked, because the supraannular valve will automatically enlarge when you put the valve, and the other valve leaflets are externally seated to the stent frame. So this is the recommended approach. So you did everything, and congratulations.
But many times it's very difficult to see the leaflets of surgical valve. It's very difficult.
You are very right. So it is sometimes, so in our country, for example, surgical reports also different can be. I mean, some problems about the sizes in the epicrizis of the patients. So it is better to look at the surgical valve. Again, if you don't like the CT, maybe repeat CT and the exact name, and use the application also, valve-in-valve application, and to know the property of the surgical valve.
Okay, I think we should move to the next case. Thank you very much, Antonis. It is Dr.